apparent that acute kidney injury is more a problem and require more attention and require more preparation to deal with this problem. But, this is some outline of what I'm going to talk about in general. So some general experience, UK experience about COVID-19, mainly focusing on the national audit data from Intensive Care National Audit Research Center. COVID-19 and AKI, what are the questions frequently asked, and acute kidney injury and acute respiratory distress syndrome. Also, AKI prevention, which is quite important in the circumstances, and renal replacement therapy option and a problem we face with that. Also to visit the option of acute peritoneal dialysis in those cohort of patients. UK experience, obviously after confirmation of the first case, following what's happening in France and Germany, and before that Italy as well. And the first case in UK was discovered on the 31st of January 2020 and has since been increasing in number. As you can see, obviously I'm not going to go through the number of cases because it's every day changing. The latest today was 831 patients had died in the UK. On the 23rd of March, the UK government has stated a state of lockdown, and obviously later on, as you can hear, 4 days later, Prime Minister was also infected with the virus. 16th of April, the lockdown extended again, so for another 3 weeks, and we're expecting this to, I think, to extend again until end of June or so. This is national data, weekly updated, and this is from the 10th of April. And I had a look at the one from released on the 17th of April as well. This is about Intensive Care National Audit Research Center, where they look at the number of patients critically unwell and get admitted to intensive care. As you can see, that the general age preference is around from the 50s to the late 60s, and obviously less number you can see in the age of 80 and above, because mostly they won't get the chance to get into ITU, because we set a criteria to who would benefit from intensive care according to their comorbidity, and the older you are, obviously you are more comorbid. And you can see how common it is in male. So male more likely, 3 times more likely to get admitted to intensive care, and actually 3 times as well there's a chance of death as well. So we don't know why is that the case. Male are more affected. This is the percentage of patients that actually requiring certain organ support in our intensive care. It's obvious that respiratory is the most organ requiring support in this case, because the virus has a preference to affect the lungs, and also cardiovascular as well because of the shock state, etc. But the renal support is not a negligible number, so that's what I'm going to focus on today. This is again from the same national data. You can see that, for example, at that time was 1,600 patients critically unwell. Half of them they don't make it out of the ITU, so percentage of death almost half of those get admitted to intensive care. Now the average duration of stay in intensive care, again, average between 4 to 6 days. For the survivors is 4 days, and non-survivors tend to stay obviously longer in intensive care. And you can see the number of patients require different type of organ support according to the organ. You can see renal support around 300 patients. This they compare this to pneumonia that's non-COVID. If you see the last column from the right-hand side, this is non-COVID pneumonia. So they compare the data to non-COVID pneumonia like flu, etc., ordinary flu, etc., from the previous a year at the same time, to look how bad is COVID and how they can deal with it differently. So this is the age distribution. You can see that's age per number. We talked about that, and female and male around female 1/3 of the population critically ill with COVID-19. Body mass index, etc. The main thing you look at is how the dialysis required. See, assistant required with dialysis is 66 patients, so around 37% require some sort of dialysis, so almost a third. Initial data from China was that is very low, even sometimes it's nil with acute kidney injury, which I'm going to show in the next few slides. So what are the frequent questions getting asked about AKI? I mean, there are a lot of uncertainty here about this type of virus and what can cause and what can damage. A lot of people asking what are the risks of AKI. It might be similar and some additional other factor. What are the causes of and characteristics of AKI in these patients? And is the virus present in the urine or not? Is it present in blood? Is it present in the effluent, in the renal replacement therapy, dialysis, or filtration? And whether should we start dialysis early when they become critically ill, going to intensive care with acute respiratory distress syndrome, or in special circumstances, what should we do about anticoagulation and whether acute peritoneal dialysis is an option when we run out of dialysis machine. Those patients admitted to hospital with COVID-19, irrespective whether they go into intensive care or not, and almost half of them actually they have blood and protein in the urine, which give you the impression that it does affect the kidney in some degree. To a certain extent. This is a study in China, published in International Kidney International Journal. This study included 700 patients, average age of 63 years old, half of them male, and they are comorbid and they have severe COVID-19, almost half of them. And they recorded 16.1% in hospital death. 5.1% only had acute kidney injury, but it showed in their analysis that acute kidney injury increased the risk of death in hospital, which is obviously the case in even non-COVID-19, because AKI in itself increases the risk of death in hospitalized patient as exactly almost like having an MI. So if you have a heart attack, it's going to affect you almost equally like if you have a kidney injury. This is from the same study showing you that if you do have, this is a Kaplan-Meier chart showing if you do have kidney impairment of some sort, either proteinuria, hematuria, or rising in creatinine, there is a significant difference in mortality and in hospital death. All of them you can see the red in the bottom, the red line. Those are who have had raised creatinine more than 1.5 milligram per deciliter, and it's all with a significant p-value. So you can see that if you got a kidney injury, the chance of death is much higher in hospital. This is again few studies from Wuhan in China. And and you can see that actually the number of AKI wasn't that overly concerned. I don't know what was the reason at the time, but increasingly we're seeing AKI in even non-critically ill patients. This is a post-mortem study. They did it again in China, and it showed that actually how does the kidney get affected in COVID-19 patient. And you can see that in the first picture here, the kidney tissue sample showing in pink color. There is acute tubular interstitial inflammation, and it does also cause some RBC aggregate in the peritubular capillaries. As you know, that it's hypercoagulable state, and the thrombi also can affect the kidney. And also on cross-sectional imaging, they have noticed that certain patients, they have even had a kidney infarct as well. But in this study, they didn't mention any of that. In electron microscopy, interestingly, that you can see also the virus in the tubule. So it does appear in the urine, the COVID-19. And the last picture is immunofluorescence showing you the nuclear protein detection and the bright color there. So what happened? Why you get acute kidney injury in critically ill patients? Generally speaking, people who have got sort of kidney problem to start with, and they go into intensive care, for example, there is a mechanism of which ischemia and hypoperfusion generally affect the kidney eventually, in addition to fluid overload issue with acute kidney injury. When you've got someone that's critically ill with acute kidney injury stage 3 or so, requiring dialysis, they get some sort of damage to the lungs, and trying to protect that, obviously, by early renal replacement therapy to try to reduce that insult to the lung, which is mediated mainly by humoral and cellular effects. Again, in a critically ill patient, also ECMO, which is extracorporeal membrane oxygenation, which is rarely used, but in COVID-19 has been used. This type of treatment, again, they think it might help reducing the inflammatory injury to the lungs. The other way around, what if you start with ARDS, acute respiratory distress syndrome, and causing later on acute kidney damage? What is the mechanism? It's mainly actually in those circumstances actually because of increasing biotrauma and barotrauma. So there is a biological, humoral, and immune response in the lung affect the kidney. And again, the same thing with increasing intrathoracic pressure, which is barotrauma, and increasing venous congestion, systemic venous congestion, which known to affect the kidney as well by causing renal vein congestion, in which eventually cause anuria and acute kidney injury, and those patients will require a dialysis eventually. So it's both way mechanism. Either you start with kidney affect the lung, or the lung affect the kidney. So we come up to a summary that actually acute kidney injury frequently observed in ARDS patient affected by COVID-19, especially in comorbid patients, and there are several mechanisms, which is we explained earlier. And kidney epithelial cell viral infection may also worsen the inflammatory response in the kidney and cause and prolong the duration of the AKI, and cause more patient to needing dialysis eventually. Comorbidity also with pre-existing kidney impairment put you at risk of having AKI. So if you got CKD, chronic kidney disease, you will be at high risk of developing acute kidney injury. But how to explain? It's difficult to explain so far. We don't know why there is a variation in COVID-19 AKI patient. Age and comorbidity and all other risk factor is obviously can be reason to explain why. But there are other factors they propose. For example, using high PEEP in ventilation, that can cause problem with systemic resistance and cause more risk of AKI and different mechanisms. Rhabdomyolysis they reported, for example, timing of RRT when you start renal replacement therapy, and use of nephrotoxic drugs, and also keeping the patient dry, because there is a myth initially started when they said since the lung is very affected, they kept the patient dry, thinking that this fluid going to damage the lung more. But actually, if those patients have a lung problem without heart problem to start with, then there's no reason to keep them dry. Actually, you're going to cause acute kidney injury in those patients if you keep them so dry, because they are dehydrated already, low intake, and they have fever. So, and they are in a hypercatabolic state, they will potentially develop kidney injury more than anybody else. Again, there is some suggestion that some genetic, link to that, and different phenotype of patient, and that's why certain patients have severe COVID and develop AKI and others don't. Now, what is renal replacement therapy in this COVID pandemic can be, how to select patient and what criteria. Obviously, indication for dialysis generally will apply the same, like fluid overload, acidosis, and high potassium. But when to start and how to use the resources you got wisely, this is an important issue to consider in this pandemic, because we can't just have the same standard treating our patients. We have to lower our standard. That's what we experience in the UK. In order to preserve the equipment, consumable, and staff. We don't have enough staff to dialyze patients and give them the required treatment, so we'll have to lower the standard in a certain way, which we're going through in a minute. For the sake of the time, obviously I might run out of time. I would like to just go on to further slide to look to the strategies how to prevent renal replacement therapy need. If you avoid patient getting into the stage of acute kidney injury that require dialysis, obviously that's an important strategy to educate the staff and the junior to fluid assess the patient before they get into AKI, and also use the loop diuretics in general to manage the fluid overload if you think that the patient is overloaded, and minimize the fluid intake, especially in between. If the patient on dialysis, for example, in between dialysis session, minimize the fluid you give to the patient, either through NG, nasogastric tube, or intravenously. Low potassium feed, obviously, to avoid more dialysis, and potassium binder. These days, I don't know if it's in Iraq available or not, but now we have two types of potassium binder that we can use. One is Peritoneal and the other one is sodium zirconium, both of which is very useful, and you will have a result within 12 hours or 16 hours. Sodium backup to treat metabolic acidosis obviously is important. So, traditionally, if patients get into intensive care and develop any of these, they will get into dialysis machine or filter, CVVH. But in these days, we have to manage them even in critical care because of the lack of resources, and we're running out of fluid and machines. We tend to use those more intensively. Now, generally in intensive care, what type of renal replacement therapy you use is called continuous renal replacement therapy, which is CVVH. And that type of treatment is obviously an ideal situation. That's what we use, but now is very limited resources. Then we'll have to look for some other source of dialysis. Initiation before onset of life-threatening complication, that's an ideal situation. But nowadays, obviously, again, we have lowered the standard, so we're not doing that anymore. Prescription of dose, the downtime, the planned time, etc., due to the fluid limit, so you can't use continuous 24-hour 7 dialysis type, but we limited, due to limited fluid, they had to cut it down. Anticoagulation is a problem again. Those patients very hypercoagulable, and you lose the circuit, and you have to replace all the consumable quite frequent in those patients. This is another reason why we're running out of supplies. Again, it requires highly qualified staff, but now we rely on much less qualified staff, and we try to train them how to set up the machine and try to use all resources available. ICU environment, that's where we ideally do that, intensive care unit, but nowadays we have used also recovery room, for example, and theater. So we stopped all non-urgent surgery, and we use most of the theater for to manage a critically unwell patient. So it's not an ideal place to manage and dialyze patient due to quite frequent reason. For example, the port for fluid you use, the reverse osmosis water you use in those machines. What is then the alternative? Well, the alternative is either use a standard hemodialysis, which is 4-hour dialysis, but again, that's not ideal because of the patient unstable in ITU, and they don't do well on that machine. But we try to modify it and make it prolonged dialysis session with a low pump sleep, what we call SLED, slow low efficiency dialysis, and that can take up to 6 to 8 hours. That's an alternative. The problem with a reverse osmosis system, most of the intensive care units in the UK, they don't have the ports for the water supply, reverse osmosis water, which is obviously, I'm sure you're aware of that, because that's what you main water supply you use in Iraq. But we try again. There's no enough resources to get those ports installed in ITU in order to use hemodialysis machine. In CVVH you don't need those ports, but in hemodialysis you do, and that's the problem we're facing at the moment. And there's no hemodialysis. You don't have to use much of anticoagulation as a standard, but in this type of patient, obviously you can use, because they have tendency to clot is more, but there's no absolute indication. Again, that's maybe life slightly easier, but again you face with the problem with the staffing issue, and the same problem. We can't send all our hemodialysis patients to intensive care because we do have our own chronic dialysis patient. And potentially you can treat more patients on dialysis, because in one machine you can use it to 4 to 5 patients a day, but in CVVH you got to use one machine per patient, and you can use prolonged hour dialysis, but you have to use it for only 3 patients. What is the challenge and what's the problem facing by using dialysis or CVVH? What has been the problem? Why we're running out of supply? The problem is because of those patients, they tendency to clot more and actually to clog the filter more. So you can see these are the kidneys we use in the dialysis machine, and it has a very tiny filament. And the filament is almost like the size of hair, the human hair, and that if it gets clotted, inside the capillary, and those are like a capillary. The blood clotted there, then the flow will be low and the dialysis efficiency will be much lower, and you have to replace the kidney. So you're going to run out eventually. So the filter patent is quite important. What is the difference between clogging and clotting? Clogging is a proteinaceous material get inside the dialyzer membrane, and it does affect the permeability of that membrane and ultrafiltration as well. The ultrafiltration, that's what you rely on to remove the fluid. It's become impaired when the filter gets clogged by the proteinaceous material, and the pores will be blocked as a result. And membrane clotting is obviously affect the flow, and you can see that from increasing the venous pressure. And it is highly prevalent in those cases, and try to prevent it by increasing anticoagulation and reducing the ultrafiltration rate, and switch from hemofiltration to hemodialysis. So instead of relying only filtration, you try to use more dialysis by using dialysate. That was the complex mechanism for those who are not nephrologists to understand that, but for the sake of the time, I'll be able to explain it fully. This is more magnified picture of where that's very high power picture to look at those pores which get clogged by this proteinaceous cake. That's the way it is. It will be blocking the filtration and efficiency of the permeability of the membrane. Again, this is what we just shown you. This is how clotting happen, and a dense fibrin under microscope showing in the first picture on the top how dense fibrin network aggregate and block those pores. And despite using some heparin, this is the case still happen. So what are the strategies to keep the filter patent? Hemodilution. You try to do hemodilution, so you try to give more fluid, regular saline flushes, and make the blood in the filter more diluted. And also use heparin. Most recommended heparin nowadays is low molecular weight heparin, so you give it to the patient to thin their blood to make it more or less coagulable, and using also regional citrate, so using anticoagulation inside the machine into the blood in the circuit itself, not to the patient. Use citrate. So now we are using both actually to minimize the clotting. Again, a very important factor is a good vascular access. If you've got good vascular access, you have a good blood flow and less likely to clog those capillaries. Vascular access, different type and different size. Obviously, you have to choose the right size to the right site, where to put it, either femoral or jugular. And different size for different machine will give you different flow. In intermittent hemodialysis in the bottom, you need much higher flow rate to do sufficient and efficient dialysis. So, and then once we run out of option in terms of usual dialysis and filtration, then we went back to think why we don't use acute peritoneal dialysis by using our biological membrane rather than using artificial one. And this is in the picture you see, if you haven't seen this before, this is the peritoneal dialysis, or what you call in Iraq غسيل بروتيني, and you use peritoneal membrane to remove the solute by convection and filtration. And this is the tube we use, usually with two cuff and curly end, usually inserted medically. And this is showing the membrane and how the convection of the solute happen from the hyperosmolar side in the peritoneal cavity to the other way. So from the blood capillary lumen to the hyperosmolar fluid. So that's you're relying on osmotic gradient force to pull out the solute out of the blood capillary. And a PD exchange, this is what happens in fluid in, fluid out. And usually the volume of fluid you use is 2 liter to 2.5, depending on the size of the patient. But remember that actually you can't use large volume in critically ill patient because of respiratory distress and because you're putting more pressure on the diaphragm. And also remember, actually, if you have to prone patients in intensive care, that's again going to compromise the respiratory and compromise the ventilation as well, in which case you can't use much fluid, or we try to avoid any fluid in proning anyway. Clearance can be increased by using a stronger fluid, so the higher concentration of glucose you use in those bags, you create more osmotic gradient and you achieve more dialysis by doing that. What is the advantage of peritoneal dialysis? Is continuous treatment, is not an intermittent, so you can carry on doing that. You achieve more solute clearance and is gentler as well. It doesn't affect the blood pressure, etc. But the problem is you need someone to do peritoneal catheter in intensive care, and you can't do it obviously surgically because you can't move the patient to theater. So bedside insertion with using cylinder technique, this is what we're doing in our hospital, and we're planning to put more patient on that. At the moment we haven't started, but we're putting in protocol in place to start doing this in intensive care. I do them myself in the ward normally, but I haven't done them in intensive care patient before. So hopefully soon we'll start that. And no need for hemodialysis machine or continuous renal replacement therapy machine as well. So you don't have any machine. Only you need some kit, some tube, some bags of fluid. That's all you need, and that's if you're doing manual exchanges. If you're doing automated peritoneal dialysis, you will need some machine, which we'll see in the next picture. You don't need anticoagulation in this type of treatment. Limited control of fluid. That's the disadvantage. The intensivists, they like to see hourly ultrafiltration rate. They would like to see the fluid management very nicely observed and documented. It is established technique in critical illness, so being used in a lot of third world countries, acute PD, because again lack of resources. It does, the advantage of that, it does need a training and education, and the advantage also no need for vascular access, but a risk of acute leak from the PD catheter and peritonitis infection is another disadvantage. This is the difference between CAPD. This is CAPD called cyclical peritoneal dialysis, ambulatory. This is one continuous ambulatory peritoneal dialysis in which you do full manual exchanges of fluid in and out of the patient abdomen. And APD is automated, as you can see in the bottom of the picture. This is the machine that allows the fluid in and out of the patient in a controlled manner. Another thing is about blood purification. Purification hasn't really proven to be of help in cytokine storm, but it's something that they have proposed. But again, you need a very intensive treatment. You have to put patient on both renal replacement therapy as well as on ECMO, extracorporeal membrane oxygenation. So to take home message, last thing, because we're running out of time, there is no universal plan. You need to change your strategy according to the need. You can't just follow another country or another place plan. You have to look what you got and plan your strategy accordingly, and put a protocol in place to use your resources. Be prepared, that's very important. Be prepared for the worst. We have done a lot of changes preparing for the worst, staffing and equipment, etc. But despite all of that, we're facing new challenges like